a physician leader, a technologist, and the chief medical officer at the helm of the fastest growing RPM and longitudinal care platform company in the US today. I'm talking about Cadence, and the chief medical officer, who I'm so thankful to have on our little show here today, Dr. Evie Cunningham. Evie, thanks for joining the Executive Uninterrupted today.
Well, thank you for having me. I'm excited to be on the show.
2 times is the attempts that we've had so far in landing
I know.
this.
I was thinking I was supposed to be on it. I think you were doing a different pod last time, but it was when I was still at Providence and it didn't end up working out. So that's when you got to meet Jessica Schlicker, who's did an absolute wonderful job at that. And then I think we tried again. So finally, we're making this happen. It's high time for this conversation for sure.
It is. And you're a hot ticket these days. Not only are you a podcaster, I didn't throw that in the intro there, but you're also, I will say, one of the most humble and open to a conversation leaders today. And you think about the ecosystem, I'm talking across VCs, healthcare, health plans. That shows, I think, a next generation leadership that many people don't consider. It's a little thing. You probably don't even recognize it, but it's a little thing that goes a long way. If you're open to exchanging ideas and to a conversation in a thoughtful way, that says a lot about a person and a leader. So,
well, that's very kind of you. You know, a lot of people have done a lot for me in my career. So I think it's really important to give back. But I also, on the flip side, and this may sound a little selfish, but in every conversation, you always learn something new. And I'm a constant learner. So I love meeting new people and talking and learning about new things. So it goes both ways.
It does indeed. And speaking of a lifelong learner, a lot of our audience is that. And we like to take a look at the leader behind the title. So I did want to start with a little Back to the Future retro for you, because a lot of the leaders we've had on, wonderful voices across government, healthcare, and tech, have talked about an interesting moment in their young childhood, their early schooling days, or even before they got into science and healthcare, what influenced their decision. And I know you didn't wake up and become CMO of Cadence, and you didn't wake up and become CMO for well over 300 physicians when you're at a health system a few moons ago. What was maybe a memory or a pivotal milestone in your personal life that took you into where you are today through healthcare and even through business? You have a business background that's very strong as well. So what took you through these windy roads to the person we're looking at today?
Oh gosh, that's a hard question. I wouldn't say there would be one pivotal moment, but probably the most influential people, I would say, in my career trajectory were, granted, I had so many wonderful people in my family that I looked up to, but my grandmother was a badass. She went to law school when she was in her 40s. I don't know.
Oh,
she
wow.
was bored or something. The kids were getting ready to get out of the house. And went to law school in Arizona, Tucson, Arizona. There were 3 women in her medical school class, in her law school class when she went to law school. And then she practiced law. My grandfather was a dentist. And they had this little office. And on one side of the office was the dental practice. And the other side of the office was my grandmother's law practice. And then there was a door in the middle that connected. And 15 years into practicing law, she had some continuance that she asked for. And the judge was a big jerk. And she was going, I can't remember what it was for. She really needed this continuance and it didn't happen. And he was kind of a jerk. And so she was screw him. He's a bad judge. I'm going to run against him. So she ran against him and beat him and became a Superior Court judge. She was the 3rd female Superior Court judge in the state of Arizona. She was on the bench at the same time as Sandra Day O'Connor, who was a colleague who became a Superior Court judge. So this is that time.
Wow.
And then she went on to do everybody hated her. And they wrote when she was 85 years old, the newspaper wrote this big article about all the stuff that she did. But she was like the first person in Tucson, first judge to be like, hey, when she took over the juvenile court, hey, I think we actually need to have like social workers for these kids that are abused. And everybody thought she was nuts. Well, they don't need anything. And she started the first guardian ad litem program. Like all of the other judges, the bar association, they would write nasty things about her. And she's like, these kids need advocates. And now it's like they have like these programs all over the country, right? So she was the first person, like when I told her I wanted to become a doctor and like do all this stuff. And she's like, yeah, like, hello, like just go be a badass. Like, because that's what we do in this family. She was my biggest cheerleader, my biggest mentor. Like when I went to med school, like I thought about maybe becoming a nurse practitioner, like maybe not, oh God, it's such a long time to go to school. I was the first like one to become a doctor in the family, on that side of the family. And we had doctors like extended family, but she was like, no, you can do this. Just go for it. You're going to be fine. And, you know, she was like a huge support for me along the way. And the other person was my dad. So my dad, he was a politician. And there's a lot of politicians in my family, a lot of lawyers and a lot of politicians. So when I decided to go to med school, they were like, yes, we need a doctor. Like,
we need a doctor. We got enough lawyers and bunches.
My grandma's also like, we need a plumber too. But like, I was like, not going to do that. Nobody ended up doing that actually. But so my dad was like, he had this like big career. He was one of the youngest vice presidents of the University of Arizona. I grew up in Arizona, and he was like up and coming, like this big administrator. When he was like 35, he was vice president, or 32 or something. And then he left in his 40s. He left that all behind to run for office. And he had made a deal with my mom, who became a lawyer, by the way. And she ended up taking over the half of the office when my grandmother left to become judge. So and she and my grandpa were together. And
gosh.
My dad decided to run for office and became a state rep and then a state senator. And I grew up like with campaigns, walking door to door. And he was a leader. He was a moderate Democrat. So he had a lot of good relationships. This is when everybody was very cordial and worked together. And they did a lot of legislation together. And I think I learned a lot by osmosis around leadership. I never thought I would go into leadership. Like that was never like what I thought my path was going to be. But through them, I learned so many lessons about leadership that then I was able to take into these other types of roles that I've gone into beyond being a physician and taking care of patients day to day.
Wow. That is exactly why we call this Executive Uninterrupted. I think that subliminal coding of leadership is invaluable. And I think just being around that environment, but I have to be careful what I say. There's a lot of politicians and lawyers in the family. So I'll ask my questions in a very litigious theme for the rest of our conversation today, Dr. Cunningham. But isn't that fascinating? We talked to a lot of people, and I've talked to a lot of people on other podcasts, and I'm sure, and obviously you have on your podcast. I think that's such a rare combination of skills that then on top of that, you have bedside empathy and a chemistry biology into care planning and decision making. And it's amazing that I won't go back to your OBG days, but I want to take a step into when you were at Providence and you were surrounded, you mentioned Dr. Schlicker, a Pearl Med that was around a lot of the work they did back then too, and her. And I think there's so many interesting legacy stories I've heard come out of Providence and still today. You became the CMO of a lot of physicians at Providence. I had mentioned earlier, I think the number is probably closer to 350, serving thousands and thousands of lives on a monthly basis. There had to be a moment in there, because that's around the time you went back, got your MBA, I believe in the timeline here. And there had to be a moment where you stopped and you thought, oh, damn, I can have a bigger impact. And probably through a combination of humans and healthcare, but also technology. Is that something that just hit you? Or was it a series of, again, atmospheric influences that took you into some of the interesting works that you had at Providence and then to where we are today?
I mean, before I was at Providence, I was at Common Spirit for 9 years. And I would say that I told you the story of my family and the mentorship I received and the encouragement I received from them. And there were other people that encouraged me in the family as well. But at Common Spirit in particular, there were a few just extremely wonderful sponsors and mentors of mine who strongly pushed me into leadership. I was
You
not...
got to drop some names. You got to drop some names.
Cliff Robertson, he's now the CEO at St. Francis Healthcare. Steve Spare, he's retired. Mike Marshall, he's a CMO at Memorial Care. I mean, they were just like, you've got to do leadership. We're going to grow you. We're going to invest in you. And there were others, Mary LaFalce, who was like my dyad partner, and Mara Burke, who's still at Carmen Spirit. She's an SVP there. They were like, let's gear you up. And they wanted to partner with me, but they also like wanted to help grow me because I was a very young leader at the time. I remember Mike Marshall telling me, like, I'm going to train you and mentor you so that you can be a CMO someday. And I said, Mike, I don't want to be a CMO. And he was like, yes, you do. And I was like, no, I don't. He also harassed me for months to do my MBA. I probably wouldn't have an MBA today if it wasn't for him. He kept telling me, so when are you going to enroll? So when are you going to do it? And so I finally did. And then Providence recruited me to come be the CMO of a medical group there. So when I got the job at Providence, I said, guess what? I got a job as a CMO at Providence. And he goes, oh, crap. I knew this was going to happen, but I just didn't think it was going to happen this fast. So I went over there. I was the CMO of a multi-specialty medical group. And the problem that I saw was like, I was like a cheerleader for these 350 docs. They were in 25 specialties. There were a bunch of GME programs. And I can lead medical groups and operations and like productivity and patient experience and all this stuff. But like I could see, I had always done care transformation stuff. Like if you look at everything that I had done throughout my career, it was always like, let's do midwives. Let's do an outpatient birth center. Let's do virtual visits. Let's do group visits for prenatal care for women's. I did that. And then in the medical group, I was like, let's have an innovation stipend for econ. Like I kept wanting us to try new things. So I knew technology could make things better. And everything that Providence was doing at the time for technology investment, it was like they kept throwing stuff into our clinical and like everybody was like revolting. Like the workflow was terrible. The technology was terrible. They were spending countless hours. The implementations fell flat. And people were like, especially during COVID, they were like losing their stuff. And so I got a chance encounter with the guy who was in charge of corporate development, who ended up becoming my boss, Wasif Rashid. And he became a mentor as well. I learned a lot from him. And
collection of coaches.
And then he was like, oh, who are you? Like, because I kept like coming with ideas and like suggestions and like recommendations of how we could like try. And I was like, we can pilot this and we can pilot that, because I could get them to pilot anything in my medical group. You know, I wanted to try stuff. He goes, who are you? So I finally convinced him to hire me. And so he hired me as his CMO at first. And then he gave me the whole telehealth virtual care portfolio. And he's like, here, you're going to take over this thing. And it was like, oh, when I looked under the hood, because my boss at the time was like, take a look under this, do a deep dive. Jessica, that was when I brought Jessica in, because she was like a telehealth guru when we were at Common Spirit together. And we like sliced and diced and dissected the whole thing. And after I came out the other end of it, I was like, well, this is just like a medical group. It's just a virtual medical group. You know, we were doing inpatient telehealth, like neurology, tele-ICU, tele-hospitalist, hospital at home. All of it was like, instead of having a brick and mortar clinic, you had a virtual sort of platform of how you were delivering the care. But from an operations, like all the things that are the underbelly of that, the revenue cycle, the billing, the compliance, the credentialing, like all those things are the same, like very similar, productivity, very similar to what you do when you run a medical group. So we hit the ground running with that we were building MedPearl as well, which Jessica talked about in a previous episode. And then we also were doing an RFP for remote patient monitoring. And so we were looking at all these different remote patient monitoring platforms and Cadence. That was when I met Chris Alchek, who's the CEO of Cadence. And we selected Cadence, brought Cadence in, scaled Cadence over a couple of years, kept that relationship going. And then eventually I joined them. And we can talk about like, why was that the right moment now to do that, or at the time to do that. But yeah, I joined them after a couple of years of implementing within Providence.
So that now has become more real. The connection from when you were practicing, how you were coerced into leadership and your MBA, for good or for worse, the coaching combination is really the underbelly of how you, I think, began to realize your own leadership skills in more real time. And sometimes I think it takes a brilliant coach to do that. And that's what I'm observing in our conversation. And I think, Evie, the one thing I'm curious of, and we skimmed over this, you were a co-founder of MedPearl. I wanted to make sure I'd mentioned that. So that in and of itself is extremely impressive, that you were guinea pig testing all these different programs to really go through the process of innovation. And it's amazing that you built a culture that was willing and able to do that at Providence. I think that's even still today very difficult for a lot of systems, or even small hospital groups that are still independent, to be able to do these things to better serve the lives that they do today. So I am curious, with what you were starting to then be in charge of, looking under the hood, you said, oh, this is really running a medical group. There was definitely probably frustrations that came along with implementing certain technologies. So I'm curious if you saw some of the, now we look back at 2019, 2020, 2021, very rudimentary technologies by today's 2026 standards. But I'm sure there was some serious frustrations. So do you still see those frustrations existing in healthcare leaders today to implement new technologies? I think Cadence has survived probably the biggest challenge of being an RPM leader, but obviously having a longitudinal platform to be able to show projected financials in terms of a care model too. So it's more of the look of a patient's life and disease state than just the technology. But is that still a struggle today? Or are you seeing a culture of physicians more willing and able to try new technologies, or technologies that have advanced that maybe aren't so old anymore?
It depends on like the use case and the problem you're trying to solve, and like what's available on the market. When Cadence first launched in Providence, they had never done an Epic integration. Okay.
Oh, wow.
So Providence was the first Epic integration that Cadence did. Now Cadence has done over 20 Epic integrations. Okay. It's like a rinse and repeat. It's like we've got it dialed in. We know exactly how many hours it's going to take. We have contractors we can work with to augment the health systems. We've worked with some of, now we know no single build of Epic is the same. You know what I mean? But at the end of the day, we've done, Epic, Athena, Cerner, like the big ones. And like, we've got that dialed in. When you're doing your first implementation or your second implementation or even your third sometimes, and you have a fairly complex integration that has to happen, and you don't know all the things, you're like learning and fumbling along the way, it can be a lot clunkier. So it kind of depends on the company that you're working with, the level of complexity of the integration and the clinical integration that has to happen, and then the technical components and whether or not both sides kind of have a good understanding of what it is that they need to do. And I think that like the benefit of sometimes being with a company that's done this over and over and over again, it's why a lot of people pick Epic as their EHR, because Epic, they kind of know what you're getting yourselves into. And so we get a lot of that where people are like, okay, you guys kind of have this wired in. The other thing I would say that Cadence does really well, and I've seen other vendors do this as well, is like we are pretty customer obsessed. And if you're not customer obsessed, especially as a health tech company, and you're not willing to listen to what the customer wants and needs and like take that feedback and then make your product better, that's like a non-starter in healthcare. That's the way you build trust. And so I've seen this play out like in real time, and I've seen like the feedback that we get because we are like very customer obsessed. And like, look, you can't customize. I mean, there's so much customization in healthcare that it's created like waste, because it's so out of control sometimes.
Significant.
So you have to be careful about what you're going to be willing to agree to. But that doesn't mean that we don't listen. And then if we can accommodate something that like we are definitely like, these people are not dumb. The health system physicians are very smart people. Like just sit down and break it down to them and explain why there might be limitations. Like don't give them fluff, okay? Like we see right through that. So I'm speaking for Cadence, but I'm also speaking like if I was on the other side, I was on the buyer side of this. And like what I would get so frustrated with, so I'll give you an example for her telehealth. For telehealth, we had a massive problem, okay? We had a 90 hospital teleneurology program, a 48 hospital telepsychiatry program. Half the hospitals we were serving were not Providence hospitals. A bunch of them were on like rando EHRs. And then we would have like 3 neurologists covering 90 hospitals, okay, across 7 states. So you had to consider licensing, credentialing, who's on call, who's available, documentation, getting in and out of the EHR. And when we went and tried to explain this load balancing, all this stuff, when we tried to explain the like problem we were trying to solve to the EHR vendor, and I'm not knocking on Epic here, but like they were like, we don't have a lot of customers who have this problem. Like, we're not going to be solving this problem anytime soon because like we've got to work on things that like everybody's asking for. And so we had to go outside. And this is what happens sometimes is like when you get ahead, too far ahead from an innovation perspective, where your EHR vendor isn't building for that problem, or maybe they can't build for it because only like 20% of their customer base needs it, right? Like that's when you start having to find solutions. And we couldn't even find things on the market that were solving for that. Like we home brewed a solution for that because there was like nothing that would solve it. And I think they're still using it today, even though it's like not perfect. Like I think they built it on Salesforce or something. I mean, it was like Salesforce is like, what are you guys doing? You're crazy. Like it's not designed for this. It's like, what's the only way we could solve the problem? And I think it's like still there.
That's
because,
unbelievable.
I mean, there's like a bunch of examples where you kind of like rig things up or stitch some little solutions together. And that being said, there's all this movement happening in the market now, especially as it comes to like innovation within the hospital room, with ambient dictation, with decision support tools. Like some of it's fragmented and doesn't all talk to each other, but it's very exciting. And I think we're in a place now where there's so much hunger from the clinician workforce to do new things, to try new things, because it's such a bad... Like if we continued with the status quo, like it just would not be sustainable to deliver care. It's so messy. And so we get excited about, most doctors are pretty excited. And like with Cadence, it's like the same thing. Like, yeah, there's some that like, you've got to sell them the care model. They've got to be interested in like wanting to sort of release some control because they're like, we're acting on their behalf when the patient's in the home. But it used to be a push, like pushing stuff in to get the doctors to try stuff. And now we're getting a little bit of the pull.
Yeah, that is probably the biggest milestone in the culture that you were speaking about, is giving up control and less of the push and now more of the pull. And I got to say, back to where you were saying we built it on Salesforce. Now, this is no longer in your purview. I can say, tell that group to get it off Salesforce. It doesn't seem like Mark Benioff is interested in AI right now. He's still on the cloud. So maybe that thing needs to move, but just a fun jest for Mr. Benioff there. But it's so fascinating because to think about the shift you've had to make has really come from the lessons you've learned relatively quickly and the things that you've tested. So we did Back to the Future. I want to go now into the future and stay there for a moment. So bear with me on this kind of little thought experiment, Dr. Cunningham. It's 2030. Let's go about 4 years out. Now Cadence is in the most ideal state, serving about 1 million lives. What was the reasons to this success? Was it the adoption like we were speaking about? Was it the enhancements around RPM, AI, still humans in healthcare in the home? Or was it the pull? You've gotten so many pulls now to realize that it has to be a standard piece of healthcare from a system perspective. Is it those things, or what is it that takes us into 1 million lives by 2030 for Cadence?
Well, I keep going back to the outcomes. I mean, at the end of the day, you cannot argue with our clinical outcomes. When you look at what we can actually do for patients when we deliver care this way, our outcomes of getting patients into control just completely surpass what you can do in traditional care delivery. We just knock it out of the park. The percentage of patients we can get into guideline-directed therapy is just completely surpasses what traditional care delivery can do, because you cannot get a brittle hypertensive patient or a poorly controlled patient with congestive heart failure or a diabetic whose blood sugars are out of control. You cannot get them into good control with an office visit every 3 months.
No
you
way.
just can't.
Too low touch.
You can't.
Yeah.
You have to do in-between care. And so in-between care is the way forward for chronic disease management. And when you look at our outcomes, they speak for themselves. But then when you take it further, okay, so like our clinical outcomes are amazing. We're published in multiple peer-reviewed journals already. We're getting published in Mayo Clinic proceedings like in the next month or two for another article. I mean, we've got multiple, right? New England Journal of Medicine, the JACC Journal. Then if you take it and you look at like our total cost of care savings, like we don't save money because we're trying to withhold care or prevent patients or do denials or something like that. We're saving money because we're keeping people out of the hospital. Okay. And at an individual patient level, when we reduce admissions by 27% in patients, that means that many patients didn't have a stroke, okay, because their blood pressure was completely out of control. That many patients didn't have a CHF exacerbation that they could have like completely died from. That many patients got an arrhythmia that was caught super early and intervened upon so the patient could have it all managed outpatient, right? And so that's an individual patient. But then when you look like just at patient experience, provider experience, health system financial, the access that we're addressing because we're like managing the in-between care, we're unburdening the clinics, we're reducing unnecessary visits. And then what we're doing for reducing total cost of care for like the payers and for CMS, like when you look at it, like if you deliver the care right, and we've been able to prove it, if you deliver the care right in that way, you're meeting that whole quintuple aim, right? Or sextuple aim. I don't even know if it's six of them now. Like there's so many parameters because we also like 2/3 of our patients live in rural areas, right? Like where, you know, it's 2 hours to get to see the cardiologist. Why are we making patients drive 2 hours for a simple check on their, you know what I mean? Like when they can do it from home. But to your other point is the AI. When we AI the crap out of our workforce, that's what I tell everybody, because that's what we're doing is like, we look at every single thing that a person is doing. I'll give you an example. We have a triage line. We have patients who are checking their vitals at home. They're getting signal like high blood pressure, low blood pressure, weight changes, heart rate changes that might be concerning. We get signal. Okay, signal comes in. We tell the patient, hey, your vital is out of range. Can you recheck your vital, right? The patient rechecks their vital. If the vital is still abnormal, then we reach out to the patient and we talk to them to find out if they have symptoms. And then based on what they answer, there's an escalation pathway, okay? Well, our nurses were spending 30 to 40% of their time when they had to outreach to the patient calling the patient, waiting for the phone to ring. Sometimes the patient answered. They left a message. Sometimes the patient didn't answer. The message thing was full. They had to call back again. Why is a human doing that?
Exactly.
Okay?
Yeah.
Like a human does not need to do that.
No.
So we built an agent that can do that part of the work. And guess what? We went from our response time to being like 2 hours to being 2.5 minutes.
Incredible.
Okay.
Yeah.
And then we like 2 to 3x the productivity of the nurses. So they're doing actually high value work that's like more cognitively interesting than sitting on the phone waiting for it to ring. And I can tell you, in every single health system, in every single role, in every single department, there is a lot of stuff like this that's being done that does not require human beings. It doesn't mean that we're replacing the human beings. It means that we were making the human beings much more efficient and working at the highest level of licensure. And that's what you have to do. You have to look at every single component and surface area of the work across every type of caregiver and think, what can we do to improve the access for this person to be able to do more? And what's like low value work? And where do you layer in the technology interventions to work in concert with the human to actually maximize their productivity?
That's probably the best phrase to anyone afraid of AI, agentic agents, whether holograms, what have you in the future, taking their expertise away from them is in concert with, or augmenting, taking the nonsense stuff out so you can do the stuff that you went to school, your expertise, your human to human care. And if that's not the highlight of our conversation, Evie, I don't know what is, because you're leading the way in what I think will become 1 million lives served by 2030 for Cadence. And who knows what the evolution of that AI layer will become in your care model, in your operating model as a unit overall. But now I'm curious, because we've come to where I like to wrap is kind of a big bet. And I don't think you're a gambling doctor, but I don't know. You could be a riverboat gambler here. And if you were, Evie, where would you place your biggest bet over the next 10 years? So we're going beyond 2030 here. And biggest bet in the terms of what do you think will have the most contribution toward advancing the healthcare society we're in today? Is it going to be around the agentic AI development? Will it be more the predicted interventions, still more of a big deployment of in-home care models, or something that we didn't even touch on today? What would be your biggest bet? You'd throw it, all the chips in, looking at the next 10 years of what's going to contribute to the healthcare society.
Well, I think there's going to be, from my perspective, 3 big things. There's going to be the longitudinal care delivery and the capability to do longitudinal care and reach patients in their home from a chronic disease management perspective that encompasses a mix between care team and AI for those types of interventions, where people are going to be like using either simple devices, complex devices, whatever. There's going to be like this longitudinal management and ability to sort of have these small touch points and continuously keeping people in touch, keeping small touch points to continuously kind of proactively manage chronic disease. So I think that that's like a big bet of mine. I think there's going to be like, if I flip to sort of, so that's like the Cadence bet, right?
Okay.
Like that this is going to be
Cadence
like a
chips.
type of care model. Like you won't be able to deliver primary care unless this part of your, like this is in your care model. You won't be able to do cardiology care without having a remote care component in the care model, right?
Yeah,
So
totally
that's
agree.
going to be completely built out, and it's going to get built out beyond, like into other specialties that are very smaller and may not have as big of a footprint, but can still have significant impact. I think there's this whole other space around longevity and like genomics that like, it's like a pea soup right now of just discovery that's happening, whether it's hyperbarics, dialysis,
Peptides.
plasmapheresis, incubator things, like
Yes.
full body scans that are going to discover so many incidentalomas, we're not even going to know what to do with ourselves. genomic testing, and like there's going to be like an integration of a lot of that stuff that's going to come together. Drug discoveries, peptides. I know that's like the hot thing. Like, well, all this stuff's going to kind of come together, and there's a lot of like messiness and longevity. But I think we're going to unlock a lot of understanding in that space that I can't tell you exactly what it's going to be or what it's going to look like. But we don't even have like standard care pathways and like guidelines around all of this stuff right now. A lot of it is like very, I don't know if you saw, like, I think it's called Nico. One of these companies just raised $700 million.
Necco Health.
One of my friends is the CMO there.
Oh,
and I'm
Sunita.
Like, what is this thing? And like, you should have her on your pod.
Are we talking about Sunita?
Yeah.
Good shout out for her. Absolutely.
So, but like, I mean, like, it's like, that is going to be really interesting. And I think there's going to be a lot of direct to consumer. There's going to be a lot of like fragmentation, what I call like the digital, non-traditional care fragmentation.
Yeah.
And health systems need to wake up because that stuff's exploding. Okay.
Yeah.
And with the Aura rings, and I mean, it's like all of that. It's just, and everybody's sort of like, well, who do I play with in this space? So there's that piece. And then the third space is I got to go back to my roots. Okay. I'm an OBGYN, and there are still patients who need to go to the hospital.
Yes.
Okay. It's not all going to be done at home. And there are things that require inpatient stays, and there are things that have to happen in the hospital. And I think there is going to be just a tremendous amount of innovation as it pertains to hospital room of the future, how we manage capacity inside the hospital, what types of things AI can augment. So like I was talking to this pulmonary critical care doc who's like, oh, like we could use AI for vent management and helping us in anesthesia in the following ways. And in surgery and robotics, I was a robotic surgeon. Like it's not going to just be like really great visualization. It's going to be actual like decision support when I'm in the OR to really help me, whether it's case prep, intra-op or post-op, to put a lot of precision around surgical excellence, right? And then how do we also like, we don't have enough nurses, we don't have enough doctors, we don't have enough care team members. So how do we like beam in different members of the team into the exam room and like stretch the workforce in unique ways and have robots that are like shepherding things rather than humans? I mean, there's all kinds of stuff that's going to happen there. So those are my big three bets.
Well, I would divide it maybe not in thirds if we're thinking about all the chips that we put on the table here, but maybe 70% over here and 20 and 10. I don't know. You might mix it up in a couple ways, but interesting perspective. I think there's probably even more shout outs you can give to mentors and even some of the people you were just running through, even CMS, the place that you're saving a ton of money for, by the way, and proving out the concept that is access from Abe and Jacob and under Oz there. And I think there's so many people that are thankful for the programmatic innovations you've built around RPM and the longitudinal care platform that really is the beautiful ship here that is revolutionizing how care is delivered and the true partnership that RPM can be for health systems. So fascinating to understand where you've come from, where you're going with Cadence. And I'm just so appreciative of take 3, if you will, of our conversation here. So thank you, Chief Medical Officer of Cadence, Dr. Evie Cunningham. Thanks for joining the show today.
Thank you.